Welcome to the deep dive. If you're gearing up for the MSRA, well, some topics are just non-negotiable.
Absolutely.
And today, we're zooming right in on one of those essentials, hepatitis C.
Mm-hmm.
Forget getting bogged down in pages and pages of notes.
Mm-hmm.
We've basically done the heavy lifting to boil it down to what you really need for revision.
Exactly. Think of this as your high-yield summary. We've sifted through the guidelines, the key studies, all that stuff, to pull out the absolute core facts about Hep C. And the aim isn't just, listing facts, but making sure they click, making those connections so it sticks for the exam.
Perfect. So let's jump right in. Okay, first things first. What exactly is hepatitis C? Let's pin down the definition.
Okay. So hepatitis C, simply put, it's a viral infection that primarily attacks the liver, and it's caused by the hepatitis C virus, or HCV.
Right.
Now, this virus, HCV, it's a single-stranded RNA virus, belongs to the Flaviridae family. What's really key to understand is how the disease progresses. It can start as an acute infection, which, well, often it's quite mild, maybe even goes unnoticed, and thankfully it rarely causes sudden liver failure. But the real worry is the chronic form. That's where the virus hangs around long term.
Right, the long-term implications.
Exactly. And that's where you see the potential for serious problems down the line, like cirrhosis, which is severe scarring of the liver.
Yeah.
Hepatocellular carcinoma, that's a type of liver cancer, and, ultimately some people might need a liver transplant.
Wow, okay.
And just a quick practical point for anyone working in the UK, hepatitis C is a notifiable disease, so if you diagnose it, you've got to report it.
Got it. Good to know. So it's that chronic form that really drives the long-term risk. How does someone actually get infected? What are the ways it spreads?
Well, the main route, overwhelmingly, is through contact with infected blood. Think blood to blood.
Okay.
So top of the list is intravenous drug use, specifically sharing needles, syringes, or, any other injecting equipment. That's a huge factor. Historically, before 1991 in the UK, blood transfusions were a risk because the blood wasn't routinely screened for HCV back then.
Oh, okay.
Hemodialysis patients can also be at risk. Sexual contact is possible, but the risk is generally lower than with, say, Hep B.
Lower, but still there.
Yeah, lower. But it increases if someone has multiple partners or other STIs. For healthcare workers, there's a risk from needlestick injuries. The transmission risk is about 3% from a known positive source.
Okay.
Then there's mother-to-baby transmission during birth perinatal transmission. The risk there is around 6%, but it's higher if the mother also has HIV.
Right.
And finally, things like unsafe healthcare procedures, maybe poorly sterilized equipment, especially in some parts of the world, or even sharing personal items like razors or toothbrushes if they're contaminated with blood.
Okay, that covers a lot.
And a really crucial point, unlike Hep A and B, there's currently no vaccine for hepatitis C. Prevention is all about avoiding those transmission routes.
No vaccine. Okay, that's key. So if you had to quickly list the absolute top risk factors that should flash like warning lights for us.
Sure. Think. Blood exposure.
Yeah.
So number 1, injection drug use, especially sharing gear.
Yep.
Number 2, receiving blood transfusions or organ transplants before, say, 1992 in the UK.
Right, the pre-screening era.
Exactly. Then being on long-term hemodialysis, being born to a mother with HCV,
Okay.
having sexual contact with multiple partners or unprotected sex with an infected partner, and for healthcare workers, that occupational exposure via needle sticks. Those are the big ones.
Got it. Crystal clear. So the virus gets in. What does it actually do inside the liver? How does the damage happen, the pathophysiology bit?
Okay, so HCV has a real preference for liver cells, the hepatocytes. It infects them. Now, your immune system obviously recognizes this invader and mounts a response. It tries to clear the virus. But here's the catch. A lot of the liver damage actually comes from this ongoing immune attack, the inflammation it causes.
Ah, so the body's own response contributes.
Precisely. The virus is replicating inside the liver cells, which keeps provoking the immune system, leading to chronic inflammation. Over months and years, this constant cycle of damage and attempted repair leads to scar tissue forming that's fibrosis.
Like scarring anywhere else, really.
Kind of, yeah. And if that scarring becomes really widespread and starts messing up the liver structure and function, that's when you get cirrhosis.
Right.
And cirrhosis itself is a major risk factor for developing hepatocellular carcinoma, the liver cancer we mentioned.
Okay. And how long does this usually take to develop after infection?
The incubation period, so the time from exposure until the virus is detectable or symptoms start, is typically around 6 to 9 weeks.
6 to 9 weeks, okay.
And just briefly on the immune side, it gets complex, but essentially different types of immune responses can influence the outcome. Some responses, involving things called Th2 cytokines, seem to actually promote fibrosis and help the virus establish chronic infection.
Oh, really?
Yeah, whereas other types, involving Th1 cytokines and certain T cells, might be better at controlling the virus and lead to less scarring. It's a bit of a battle within the immune system itself.
Fascinating. So it's not just the virus, but how the body reacts.
hmm
Okay, if someone comes in with liver problems, maybe abnormal LFTs,
Yeah.
what else should be on our radar besides Hep C? The differentials.
Good question. You definitely can't just assume it's Hep C. You've got to think about other viral causes. Hepatitis A, B, D, and E are all possibilities.
Right, other letters.
Exactly. Then there's autoimmune hepatitis, where the immune system attacks the liver directly.
Okay.
And always consider drug-induced liver injury. So many medications, even herbal remedies or toxins can upset the liver. So yeah, a few key things to rule out.
Makes sense. Need to keep those in mind. Now, zooming out a bit, how big a problem is hepatitis C? What's the epidemiology like, say, in the UK and maybe globally?
It's a significant public health issue, no doubt. In the UK, as we said, a lot of transmission has historically been linked to intravenous drug use. His estimates suggest there are around maybe 214,000 people living with chronic HCV infection in the UK. And the scary part is about 3/4 of people infected go on to develop chronic disease.
Wow, 75%.
Yeah. And of those, maybe 20–30% could develop cirrhosis over about 20 years. We've also seen worrying trends in the UK with rising numbers of Hep C-related deaths, liver transplants needed, and hospital admissions.
Concerning.
Globally, it's even bigger. We're talking over 180 million people infected worldwide. A huge challenge is that many people don't even know they have it. They're undiagnosed.
Diagnosed, yeah.
There are different genetic types or genotypes of the virus, 6 main ones. In the UK, genotypes 1 and 3 are the most common.
Those the genotype matter.
It used to matter a lot more for treatment choices, but the newer drugs are effective across most genotypes. Still important to note, though, high-risk groups remain people who inject drugs, those pre-1992 transfusion recipients, and people from countries where Hep C is much more common. The good news: new infections seem to be decreasing, probably thanks to better prevention, harm reduction, and crucially, the really effective treatments we now have.
That's positive.
But for those who do develop cirrhosis, the risks are still there. About 1–4% per year might develop liver cancer, and 2–5% per year could go into liver failure.
Those stats really hammer home the need for diagnosis and treatment. So how does it actually present? What symptoms or signs should make you think of Hep C?
This is tricky because often there aren't any obvious signs, especially early on.
The silent nature again.
Exactly. Acute hepatitis C is often asymptomatic. Maybe some people get vague flu-like stuff, feeling tired but nauseous, some tummy pain.
Right.
Only about 20–30% might actually get jaundice, the yellow skin and eyes, or have clearly raised liver enzymes if they happen to get blood tests.
Okay.
If symptoms do appear in that acute phase, it's usually around that 6–7 week mark post-exposure we mentioned. And remember, a decent chunk, maybe 15–25%, actually clear the virus themselves spontaneously.
Oh, okay. So not everyone goes chronic.
Not everyone, no, but the majority do. And chronic hepatitis C is typically even more silent. People can have it for 10–20 years, feeling pretty much okay.
So how is it usually picked up then?
Often, it's an incidental finding on routine blood tests. Someone has liver function tests done for another reason, and the ALT enzyme is elevated. That prompts further investigation.
The abnormal LFT.
Precisely. Eventually, if symptoms develop in chronic disease, they tend to be quite nonspecific. Again, persistent fatigue, general malaise, maybe some upper abdominal discomfort. Later on, you might see jaundice, dark urine, pale stools.
Okay.
On examination, you might find jaundice, an enlarged liver, hepatomegaly, or tenderness when you press on the upper right abdomen.
And you mentioned it affects other parts of the body too, extrahepatic features.
Yes, absolutely. It's not just confined to the liver. You can see things like arthritis or joint pain, cryoglobulinemia, which can cause rashes, kidney problems, nerve issues, a skin condition called porphyria cutanea tarda, increased risk of diabetes, lichen planus, which is another skin mouth condition, Sicca syndrome causing dry eyes and mouth, and even a link to non-Hodgkin's lymphoma.
Wow, quite a range.
Okay.
So definitely need to think beyond just the liver symptoms.
Definitely.
Okay, so Given it can be so hidden, how do we actually go about diagnosing it? What are the key investigations?
Right. Diagnosis usually starts with thinking about screening. So in primary care, you'd consider testing anyone with unexplained abnormal LFTs or people in those high-risk groups we listed.
Makes sense.
The first test is usually an antibody test, the anti-HCV serology. It looks for antibodies the body makes against the virus.
Okay.
This usually becomes positive within about 3 months of infection in most people, nearly everyone by 9 months.
So that's positive.
If the antibody test is positive, it means they've been exposed at some point. But it doesn't tell you if the infection is still active. So the next step is the HCV RNA test.
The RNA test.
Yeah, this looks for the virus's actual genetic material. If the RNA test is positive, it confirms an active, ongoing infection.
Got it. Antibody positive, then RNA positive equals active infection.
Exactly. And if the RNA is positive, we'd usually do genotype testing next to see which specific strain it is. Helps guide treatments sometimes.
Okay. What if the antibody test is negative?
Well, if someone had a very recent high-risk exposure, say in the last few months, it might be too early for antibodies to show up the window period. So you might need to repeat the antibody test a bit later, maybe 3-6 months post-exposure.
Right. The window period.
And another scenario, if the antibody test is positive, but the initial RNA test is negative, meaning exposure but no active virus. Now, you might repeat the RNA test in 6-12 months just to be absolutely sure the virus hasn't just fluctuated or if they cleared it spontaneously.
Okay, thorough approach. What about other baseline tests?
Yeah, alongside the specific HCV tests, you do standard baseline bloods, full blood count, kidney function, UNEs, liver function tests, LFTs, a clotting screen,
Right.
HbA1c to check for diabetes, thyroid function, maybe ferritin levels. You'd also want to check their status for hepatitis A, hepatitis B, and HIV, as co-infections are important.
Okay.
And if you suspect it was sexually transmitted, screening for other STIs makes sense too.
And then specialists might do more.
Yeah, specialists might do more detailed tests, viral load to quantify the amount of virus, maybe look at clotting more closely, check for autoantibodies, and critically, they'll assess liver damage. Often now using non-invasive tests like transient elastography fibroscan, which measures liver stiffness.
Hyposcan, right.
Or sometimes, though less common now, a liver biopsy might be needed. And if someone has significant fibrosis or cirrhosis, they'll need regular liver ultrasound scans to screen for liver cancer.
Okay, comprehensive workup. So let's say we've got the diagnosis confirmed. What's the plan? How do we manage hepatitis C?
The really great news is that management has been completely revolutionized in recent years. The goal now is cure.
Cure. That sounds promising.
It really is. We use antiviral medications, specifically direct-acting antivirals, or DAAs. These drugs directly target the virus's replication cycle.
EAAs.
Alongside the medication, obviously regular monitoring of liver function is needed, and lifestyle changes are super important. And generally, management is handled by specialists.
Right, specialist referral.
Definitely. Now, if it's acute HCV, you'd assess them quickly. Often you monitor for the first few months to see if they clear it spontaneously. If not, treatment might be started even in the acute phase to prevent it becoming chronic.
Okay.
For chronic HCV, specialist referral is standard. They'll confirm the diagnosis, stage the liver disease, and usually recommend starting treatment pretty promptly to eradicate the virus and stop further liver damage.
And the lifestyle advice.
Crucial. Absolutely, stopping alcohol is key, as alcohol massively accelerates liver damage. Stopping smoking is also advised. Maintaining a healthy weight and diet helps too.
Makes sense.
And counseling is important, helping patients understand the infection, how it's passed on, how not to pass it on, like practicing safe sex, not sharing razors or toothbrushes.
Great risk reduction.
And encouraging them to let close contacts know so they can get tested too. We also offer vaccination against hepatitis A and B to protect their liver from other hits.
Good point. And the treatment itself, the DAAs.
Yeah, so these DAAs are now the standard of care. Gone are the days of long, difficult interferon injections with lots of side effects.
I remember hearing about those.
Yeah, they were tough. The DAAs are tablets, usually taken for 8-12 months, much better tolerated and incredibly effective. We're talking cure rates, what we call a sustained virological response, or SVR, of over 95%, often over 99%.
Wow, over 99% cure rate. That's amazing.
It really is a game changer. SVR basically means the virus is undetectable 12 or 24 weeks after finishing treatment, and it stays gone. It's considered a cure.
Fantastic. What about liver transplant?
Liver transplantation is still the ultimate treatment for people who develop end-stage liver disease or liver failure due to Hep C, although ideally we treat and cure them before they get to that stage. Recurrence of HCV used to be a big problem after transplant, but even that's manageable now with DAAs.
Okay. And kids.
Children with chronic HCV can also be treated, usually with specific DAA regimens depending on their age, genotype, and how severe the liver disease is. That's definitely specialist territory.
Right. And after cure, is that it?
Mostly, yes, in terms of the virus, but long-term follow-up might still be needed, especially for people who already had advanced fibrosis or cirrhosis before treatment. They still need ongoing surveillance for liver cancer, even after the virus is gone.
Ah, the cancer risk might persist even after cure if damage was already done.
Exactly. The risk is
Right.
reduced, but not zero if you had cirrhosis. And just to reiterate, needlestick injuries need urgent assessment and follow-up, and suspected cases need notifying to the health protection team.
Got it. So with these amazing treatments, what's the overall outlook now, the prognosis?
It's dramatically improved. Honestly, the prognosis is generally excellent with the DAAs. We achieve cure in the vast, vast majority.
That's great to hear.
And curing the virus significantly reduces the risk of developing cirrhosis, liver cancer, and needing a transplant. As you'd expect, the earlier you diagnose and treat it, the better the outcome, because you prevent that long-term damage from accumulating.
Right. Stop it in its tracks.
Exactly. Achieving SVR, that sustained virological response, basically halts the disease progression for almost everyone. While, as we said, someone with pre-existing cirrhosis still carries some residual risk of liver cancer, successful treatment is still hugely beneficial for them too. And remember, even without treatment, 15–45% clear it on their own acutely. But for the majority who don't, treatment is now incredibly effective. Historically, some genotypes, like type 1, were seen as tougher, but DAAs work well across the board now.
Really positive shift then.
Yeah.
Okay, last big area. What are the potential complications we need to be aware of, especially if it goes untreated or progresses?
Well, the main ones are related to the liver damage itself.
Uh-huh.
Chronic inflammation leads to fibrosis, which can progress to cirrhosis in, say, 5–20% of people with chronic infection over decades.
Okay.
And cirrhosis significantly increases the risk of hepatocellular carcinoma liver cancer. That develops in maybe 1–5% of people with HCV cirrhosis per year. So it's a serious risk.
For a year, right.
Yeah. And also liver failure, where the liver just can't do its job anymore. But then there are all those extra hepatic things we touched on earlier.
Right. The non-liver problems.
Exactly. Things like joint problems, arthralgia, arthritis, eye issues like Sjogren's syndrome causing dryness, that cryoglobulinemia, which can affect skin, kidneys, nerves, porphyria cutanea tarda, the skin blistering condition, kidney disease like membranoproliferative glomerulonephritis, and increased risk of diabetes.
Diabetes too.
Yep, and links to other autoimmune type conditions like thyroiditis or skin things like lichen planus or blood issues like immune thrombocytopenia, so it can have really widespread effects.
Definitely paints a picture of a systemic illness, not just liver.
Yeah.
Are there factors that make it progress faster?
Yes, certain things accelerate the liver damage. Being overweight or obese, drinking alcohol, that's a big one, having diabetes, being male, getting infected at an older age, and having co-infections like HIV or hepatitis B. Also, being on immunosuppressant drugs can worsen things.
Okay, good to know those accelerating factors. Any red flags for liver cancer developing?
Yeah, things like unexplained weight loss, or if someone with known cirrhosis develops new symptoms. Blood tests might show a rising alpha-fetoprotein level, which can be a tumor marker, although it's not perfectly reliable. That's why the ultrasound screening is so important in cirrhotic patients.
Right, the surveillance.
And just a quick historical note on the old treatments, ribavirin could cause anemia and was dangerous in pregnancy. Interferon caused nasty flu-like symptoms, depression, fatigue. We're lucky to have moved on.
Definitely sounds like it. And prevention, since there's no vaccine.
Prevention is all about harm reduction. Focusing on high-risk groups like people who inject drugs, education about safe injecting, providing clean needles and syringes, opioid substitution therapy, for sexual transmission risk, promoting condom use, basically interrupting those transmission routes we talked about at the start.
Okay, that ties it all together nicely.
Yeah.
Phew, that was a really thorough run-through of hepatitis C. I think for anyone revising for the MSRA, that covers the core ground brilliantly.
Yeah, hopefully that hits the key areas, what it is, how you get it, who's at risk, what it does to the liver and body, how it presents or often doesn't present, how we test for it, and critically, how we now manage it so effectively.
Absolutely. And thinking about recall for the exam, remembering those transmission routes is key. Maybe thinking about things like blood, transfusions, pre-92, blood products, blades, sharing razors, etc., birth, perinatal, bang, Needlestick,
Mm.
and bonk, sexual contact, plus the big one, IV drug use behavior. Silly mnemonics sometimes help.
Whatever works. And remember those extrahepatic features too. They can pop up in questions.
Definitely. And understanding the management shift to DAAs and the high cure rates is crucial now.
Absolutely. And beyond the exam, understanding Hep C is just vital for good clinical practice. It's still a major health issue.
So true. If you want more resources to nail the MSRA, do check out pastthemsra.com.
And also freemsra.com for, well, free questions and resources, which is always good.
Always good. Thanks again for joining us for this deep dive. We hope it's been a really useful, high-yield session on hepatitis C for your revision.
Hope so too. Good luck with the revision.
Join us next time on The Deep Dive.